thank you very much. As you know, every year we give a brief update on Surveillance Center, a quick overview of what we do, and then we take questions and answers and introduce you to some of our staff. So in summary today, we'll just do a very, very brief overview of what the center is and its history, give you some very basic info on some of our findings, pretty much restricted to autopsy findings. And then most of this will just be question and answer panel with the people up here, as well as the people in the audience. So the mission of the center is started in 1997 at Case Western by Dr. Pierluigi Gambetti, and by the way, yes, we have a memorial lecture for him that Dr. Knight gave, but he is still living. There's nothing happened to Dr. Gambetti. I forgot to mention that yesterday. Multiple people have asked. Honorary, yes. Did I say memorial? Oh, yeah. No wonder people think he passed. So no, he's very well. So it was started in 1997 in collaboration with CDC out of basically what happened with the variant CJD epidemic in the UK. We wanted to conduct neuropathologic surveillance to make sure that the US didn't have cases of variant CJD. And the neuropathologic surveillance activities are funded solely by CDC. And the reason why they do that is that's the only way to allow for a definitive diagnosis of prion disease. And perhaps most importantly, for surveillance purposes, it's the only way to know for sure what caused the CJD. Is it sporadic? Is it genetic? Is it variant? And allows us to also do neuropathologic and biochemical surveillance for perhaps new forms of prion disease that may come our way, such as chronic wasting disease in humans. Importantly, the Prion Center focuses on preventable forms of prion disease through its neuropathologic surveillance, including things like variant CJD, but also medically transmissible forms of CJD, and of course, looking for new prion diseases that may arise. However, we have many other different aspects of the Prion Center that has arisen over the years. I feel like every couple of years we add a new bubble, running out of space now, but really the core of the Prion Center is neuropathologic surveillance, which I just reviewed. That's basically autopsy coordination and neuropathologic characterization of the cases, what type of prion disease it is. However, in order to improve our autopsy program, it's often helpful to help physicians diagnose prion disease. So Dr. Gambetti started a clinical laboratory that's since expanded quite widely to do clinical testing, and this includes spinal fluid testing. As you all know, we do 3 tests, 1433, tau, and RT-QuIC, and we also do clinical genetic testing on patients that are living as well as deceased. We, of course, do research. Most of our research is characterization neuropathologically of cases to make sure that we know what type of prion disease it is, that it's not a new form of prion disease, also improving diagnostics and biomarkers. And very importantly, we have a very large biobank that you'll hear about a little bit later today. And that allows us to store tissue so that other researchers can request tissue for their projects. And in fact, I just spoke to a researcher earlier about that. So that's a very big part of our center. We do outreach and education. A lot of this is in concert with CDC, state public health departments, but also especially with the CJD Foundation. We've updated our website. And also we try to throw as many publications out there as possible with a variety of audiences, whether it be funeral homes, morticians, neuropathologists, neurologists. We provide a lot of consultations. The physicians often call. We get, and Benita can probably tell us, are we down to 2 calls per day about 1433s? At least, yeah. So. But we provide consultations with physicians, state health departments. We have the MRI consultation program that Dr. Beasy helps us with. And I have a clinical longitudinal telemedicine study that I know several people have been in the audience. So a variety of different consultations to help people understand the disease, diagnose it. And then I think recently what's kind of arisen as a responsibility for us is just kind of our one-stop shop for prion diseases. We definitely have a responsibility to help facilitate advances in treatment. And what we mean by that is guide and inform clinical studies. Oftentimes, people are diagnosed initially because of a positive RT-QuIC. That allows us quick and rapid access to patients that may be have the opportunity to participate in a clinical trial. So we hope to be able to facilitate that rapid diagnosis and enrollment, and also help inform other people, including clinicians, that clinical trials may be on the horizon. So this is a similar study graph that you saw from Dr. Maddox. The difference is this is just neuropathologic positive cases of prion disease over time. Again, you see a lot of waxing and waning that happens when you look at these types of statistics. You do see a general overview or increase in cases over the year. A lot of that has to do with diagnostics, as well as autopsy ascertainment rates. But basically, it's been fairly stable, the number of prion-positive cases that we've gotten neuropathologically at least. But as you heard from Dr. Maddox, there are other ways that we track prion disease cases in our country as well. And this is a table that is very unwieldy, but I'll walk you through it. And it's posted on our website. It's updated quarterly, and you're welcome to look at it. Basically, it's the number of autopsy referrals we get every year. You can see that usually varies somewhere between 300 to 400. The number of prion-positive cases that we get, and that tends to always be on the order of about 70% positivity rate. And then we also break them up into sporadic, familial, or iatrogenic, and variant CJD. As you heard from Dr. Maddox, we've only had 4 cases of variant CJD in our country, all of which were thought to have been acquired overseas. As you also heard from Dr. Maddox, RT-QuIC is becoming an increasingly important way to survey and track prion disease cases. So we also report on our website the number of RT-QuIC positive cases that did not go to autopsy. So when we updated the clinical criteria in 2018, for probable and definite CJD, we now can make a laboratory diagnosis of probable CJD with that positive RT-QuIC diagnosis, and that allows us to add these CSF-only RT-QuIC positive cases with the prion-confirmed autopsies, and that gives us a rate that's very, very close to what Dr. Maddox and CDC sees when they look at death certificates. So RT-QuIC has also been very helpful for surveillance. So I'm going to shut up now, and we're going to do our panel. Why are you guys laughing? So I just want to mention we have about half the center here, so if the center staff could also stand up that are in the audience. Of course, we can't bring everyone up here. The stage would collapse. And then we also have Aaron Koth as well, who kind of deserves special mention because he's not technically part of the center, but he might as well be. He's kind of like that kid that lives in the neighborhood that you always find over your house, that you just assume he's staying for dinner. But to be honest, he's been a great addition to the center. We convinced him to quit his hospital job and pretty much works only for us as a consultant, and we're greatly appreciative. He also sponsored a table here at the conference as well, so he's very dedicated to the families. And of course, we hope that you interact with us during this Q&A session. Otherwise, it's going to be kind of short. So I'm just going to start and have everyone introduce themselves and just give a quick blurb of what you think's been important, what's happened at the center. So Tatiana?
Sure. Hi. I have been in clinical laboratory for all of my career. So I'm a medical laboratory scientist, and I'm a certified professional in healthcare quality. So those 2 skills is what I was hoping to bring and contribute to the Prion Center specifically. Our small team, we have half of our staff here, but the other half are back in Ohio. There's about 12 of us that are processing those almost 7,000 samples that are coming in annually for the year. So it's a significant amount of work that a small group does, and really proud to be leading that team. My other big hat at the center is our repository, so the freezer farm that we like to call it. I monitor it daily and take care of all 30 of our freezers to make sure that all of the samples that we get from all over are cared for, organized, and ready for, research requests and things like that. So yeah, those are kind of my big contributions, is hopefully just optimizing, supporting the directors, and the goals for the research. So
Tatiana's been excellent because she has such a clinical laboratory background. She's actually made us to be a much more efficient clinical lab. So an example of that is our turnaround time for CSF testing. Debbie and I will lament It used to be sometimes weeks, and now it's almost consistently under a week.
days.
Yeah, 5.2 days apparently. So thank you very much for that. Dr. Shetty.
Good morning. Before I talk about myself, I would like to say that without Tatiana, I would be dead by now. No, seriously, I'm very blessed that she decided to come to our center. I mean, Brian has always been great, but I work very closely with her, so it makes my daily life livable. Sometimes I'm not sure what I'm doing, but let me tell you about myself. I've been in the field of lab medicine for almost 20 years, so I hope I didn't give away my age. I have hidden some of those, okay? Okay. So I'm a board-certified cytogeneticist by heart, but molecular was forced on me because with the changing evolution in my field, I felt that I was being left behind if I didn't do molecular training. So I left my cushion job at the Cleveland Clinic, and I decided to move to university hospitals. And in the beginning, I regretted it, but later on, I realized that was the best decision of my life. I wouldn't be here if it wasn't for that move. So I got my training done. This is at an age where your neurons are going down, but I passed the boards in first attempt. So if I can do it, anyone can do it. So it's never late. You should tell Obama he can change his field. So I've been at the Prion Center, and I'm very blessed to be with great people and nice people, not just intelligent people, but very collaborative people. And thank you, CDC, for supporting my molecular lab, because without that, you would be getting your molecular results probably in 6 to 8 months. Now it is at 2 weeks turnaround time. So thank you very much.
Yeah, so just to kind of clarify, before the Prion Center, we did not do genetics in-house. We would send it to our associated hospital, and they would do it. But when Dr. Shetty joined as the CLIA lab director, she wanted to bring the genetics in-house, so we're able to do everything in-house now, including the genetics, which is more cost-effective, but also just allows us a lot more control in things like turnaround time, but also allows us to do pretty exciting research projects as well, like your CJD Foundation grant. So I think I would probably be dead if it wasn't also for Dr. Shetty and Tatiana. They certainly allow me to go through clinic and not have to check my email in between patients.
And we keep you honest, right? We are very open with him, so it's nice.
Yeah.
You can, with Dr. Appleby, you can say whatever you want.
Because
That's
Lord
the
knows
best
I'm going
part.
to, right?
No, don't kill him. He's very nice.
All right. Dr. Noguez.
All right. Hello, everyone. My name is Jamie Noguez. I am the director, or I should say the medical director overseeing the CSF testing. I've been a clinical lab director for about 10 years now, but I recently joined the Prion Center in 2020, right at the beginning of the COVID pandemic. And so it took a while to get started, to learn the lay of the land. When I started, all the tests that we have available in the CSF lab, they were already there. They were already established. So a lot of what I focused on is trying to improve them, to make them more efficient, to constantly scan to see what new tests are out there and what new technologies are out there that I can bring in to improve the testing even further. But it's already a very good test, right? Or Too Quick, we know it's a very good test. I'm also very thankful that I'm a grant recipient from the CJD Foundation, which allowed me to work on projects that I know are going to impact the clinical testing that we do. So things that I hope will further decrease the turnaround time. I mean, five days is amazing, but if we can make it any faster, if we can work with the reference labs or the places that are sending us the samples to further cut that down, then that's my mission. So it's been a pleasure to work for the center, and this has been such a wonderful experience to meet the families and to have validation that what we do is so important and directly impacting people. So.
Last but not least, hello everyone. For those of you who do not know me, my name is Danielle. I am the autopsy manager at the Prion Center, the program manager. I've been with the surveillance center for 20 years now. And our team is comprised of actually 3 other coordinators. We acquired 2 more coordinators this year. One of them is Benita, who is sitting in the back, who probably will kill me for naming her. But our team, basically, we service you all. We are here for you. Erin, like Dr. Appleby said, is one of our major assets, who actually has been instrumental in cutting down the time frame of when the procedure can take place, because he is so readily available. So we appreciate that. But that's me. So I work with an awesome team, really awesome team.
And of course, it's unfortunate we couldn't bring everyone up here, but of course we have other people that work in the lab, in the histology lab, which helps prepare the slides for Dr. Cohen, the neuropathologist, to look underneath the microscope. We have people that work in the Western blot lab, which basically is looking at the abnormal prion protein from the brain tissue. We have someone who's very helpful in coordinating all these reports and getting them out, whether it be the autopsy reports or spinal fluid reports. And of course, Bonita coordinates things, but she also is kind of the first line shop for when people call the center with a variety of different questions. And that could be physicians, public health people. Some of you guys may have spoken with her. Who else do we have there?
Data extraction.
Yes,
Yeah, it was Casey. Casey always hides. Casey actually has really helped a lot too. She's our database manager, and it's really been helpful. She's helped us make a much more efficient use of the way that we use our data, generate reports, even getting reports directly to state public health departments in a much more efficient way. It definitely has made our lives a lot easier. So I think that's everyone. So I think that the floor is open for questions. If you want to ask these wonderful people any.
I just had a question, Dr. Appleby, about the one slide you showed with the numbers of autopsy. This one. The number of autopsy-related referrals in CJD cases and then the CSF only. So if I'm interpreting this correctly, if you take the graph on the left here and you were to add it to the RT Quick numbers, that's giving you kind of roughly the total in any given year of CJD cases? Is that?
That's correct.
That come through?
Yep.
Okay.
So a definite diagnosis would be on the left table, right? These are brain confirmed. But again, now we're able to do probable diagnosis looking at just RT-Quick positive. So that would be your probable cases. So if we add those two together, we get a little bit north of, I think, 500, which is very close to what Dr. Maddox and the CDC is finding with death certificates. So.
And so we're still seeing kind of roughly, if I look at this real quick, like a 50-50 split between total cases that maybe go to autopsy and those that are diagnosed just off of, or those that are categorized just off the RT-Quick results. Is that?
Well, a lot of the ones that go to autopsy were also diagnosed by RT-Quick.
Okay.
But the right-hand table are ones that we only have RT-Quick data on because
Okay.
they didn't go to autopsy. So I think we're still around 60, 70% of all of our cases we're capturing through autopsy.
Okay.
Which is much better than most countries, right? I mean, of course, we want the most that we can get, but it's still not that bad. So.
Realizing that the decision to do an autopsy is a very personal one for the family, perhaps you guys can talk about what happens when a family decides they want an autopsy. What should they do? And then does that brain tissue automatically go into these 30 freezers that you have, or is that something separate that the family has to do to make sure that that happens?
I'll let Danielle answer the autopsy question, then I can answer your storage.
So you are correct. Deciding to donate is a very personal decision. So those who have, we do appreciate it. If you are interested in a selfless act, really, there are forms that will need to be completed, for our facility. So essentially what you guys would do is reach out to either the foundation or us and basically request a consultation. So our team will walk the family through the entire process, from who's authorized to sign the documentation, the likelihood of where the donation will take place. Our goal is to always try and keep the family member as close to home as possible. If that is the case, that is where, Aaron will come into play. But we try and keep the family member as close to home as possible. If not, we always keep the family abreast of when the transfer will take place, when their loved one is expected to come back, how long their loved one will be in our care, that kind of thing. So we try and keep everyone apprised of the steps along the way. We lay it out for you ahead of time so you can actually have it in black and white so you can see what's going on or what's anticipated or expected to happen. Once the donation take place, then your loved one will basically remain at the center, which is where Tatiana comes into play with the second part of the question.
Yeah, so everything that is sent to us is cared for and stays with us. We have a 24-hour monitoring system so that all of, whether it's frozen or fixed, we have special storage for if there's other tissues that are sent to us. And it's every day I can see the status of it on my phone, and it'll let me know if anything's wrong, because we want to make sure that we're maintaining the condition and care for everything that comes to us. So it's always monitored. It's always being cared for. Yeah. So
How long can it
for
be?
it's stored forever. We fix it, and then the ultra cold freezer holds it forever. So yeah, we keep everything forever.
We have cases from before 1990 even, before the center was created, from Dr.
Yeah.
Gambetti. But essentially, we act like Aaron does all the cases, and sometimes it does feel that way. But we actually have providers that will help us remove tissue around the country. So, Danielle and Megan have an excellent network, and they identify where you are in the country, who's more likely to do the services. They remove the tissue, send it to us, and we do, 4 different analyses, essentially. We do the histology, where the neuropathologist looks under the microscope. We do the Western blot, where we look at the prion protein type. We do genetic testing to see if it's a mutation and what that codon 129 polymorphism is. And as soon as Tatiana and staff receive all that tissue, they divvy it up to the labs that do the work. Casey has it entered into the database. We can track it where it is at all times and where the process is. So.
Not a question, just a statement. As a Catholic, it's really important to me and my family to know that the body after death is taken care of and respected. And I just really appreciate how much care you put into preserving what you did. And I think my brother would be very happy to have his brain where it's at right now.
Thank you.
The question I have is, we donated my husband's brain. That's how we found out it was genetic. So he had the E200. Do you guys keep a record of all of the cases of E200 to kind of see if there's some kind of, I don't know, just do you separate and keep that for research, or just so that you see how many cases of E200 there are? And
Yeah, so every time we diagnose a case and, we say it's genetic CJD from a mutation or sporadic CJD of this or that subtype, Casey's able to pull up all the cases that we have of that. So the researcher came to me and asked me for a specific genetic prion disease, and do you have these cases? And we can say, yes, we have this many of cases, this is the type of tissue we have. And I neglected to say, we actually have a formal process where researchers can request, right? So they'll request that they want certain specimens, and we have a committee comprised of myself, Dr. Cohen, Dr. Kraus. Then we review their research project, make sure it makes sense, and the amount of tissue that they're using makes sense, because we want to maintain our repository, and have respect for the tissue and whatnot. And very rarely do we ever, reject a request. Sometimes we'll say, you know, did you think about this? Maybe you want to do this, or do you think you can get by with a little bit less tissue? These are rare cases, that kind of thing.
I do have one other question related to that.
Can you use the microphone, please?
Both of my daughters ended up being negative, which was wonderful. But they both want to donate their brains because they didn't know if it would be anything as far as if you have a parent that has that, your chances, I know you say 50-50 now, but they didn't know if that would benefit if they did that too.
Yeah, so unfortunately, we're really dedicated for prion disease research. So if they tested negative for the mutation, yeah, then we wouldn't be able to use our precious funds to do that. Although we would take the brain if someone else wanted to do the procedure and send it to us. We could certainly take it and use it as what we'd call a control, but we wouldn't be able to use our resources to help coordinate it. So.
First of all, thank you so much for all that you do. It's just incredible. In my personal experience, in our experience, Danielle, specifically the process that you just explained, we were fortunate in that the hospital immediately gave me the forms. In fact, they gave me the forms right after diagnosis, and I looked at them for a few days before I could fill them out, but they were the ones who brought you to my attention. But I'm wondering, again, we were fortunate. We were in Grand Rapids. We were at a large hospital system. What happens to folks who are, in more rural areas or smaller hospitals, and maybe they don't have the knowledge or the prerequisites to do that? What's being done to get this all out to everyone?
That's where our funeral home education comes into play. A lot of the families that we have that are in rural areas, typically the initial contact comes from the funeral director. The funeral director will be notified by the family of the possible diagnosis, and majority of the time they've never heard of it. So then they go on any search engine and they kind of look up. Luckily, we are fortunate to be the place that pops up pretty much for anything related to prion disease. So a lot of times, like I said, that initial referral in rural areas will come from funeral directors. Sometimes it'll come from hospice nurses, social workers are key, very important. So they reach out to us, and then we are able to facilitate the paperwork with them. But outside of those aspects, really, if someone isn't able to look up CJD or look up prion disease or do their own initial investigation, a lot of times those cases or those family members are literally, lost to the process. And they typically move on with their funeral arrangements, which is very unfortunate. But again, it's all about the education. We can't, stress that enough here and abroad. Everything starts with education. Everything starts with communication. Everything starts with outreach. And that's what we're here to do.
I think a major advocate for our services is the CJD Foundation.
Most definitely.
Yeah, so, if we know that if any family member's in contact with them, they're going to be made aware of, the autopsy program, the MRI, consultation program, and a lot of our referrals come directly from them. So
Yes.
We're very thankful for that.
Yes, this question is for Danielle because she helped us to get my daughter's brain tissue to Case Western. After my daughter passed away, I didn't realize that Johns Hopkins kept her brain tissue and did not send it to you guys. So can you imagine losing your loved one and then realizing that her tissue is not where it's supposed to go? And I think it was about a month before you were able to get her tissue, and that's only because after I went to get the results, you all said you didn't get her tissue. Danielle got on the phone and spoke with the guy in charge at Johns Hopkins and told them, if you didn't get it to me within the next 48 hours, you're gonna have, we're gonna have some things to discuss. And by the next day, it was on her desk. So I just want to give a quick shout out to Danielle, because I was beginning to think that what happened to my daughter didn't matter to anyone. And we suffered all the way through trying to get exams, trying to get tests, trying to get results, and then imagining when your loved one is gone and still she's sitting, she's in someone else has her and she's not where she's supposed to be. So I just like to say thank you, Danielle. And I like to also want to know, have you improved the relationship with Johns Hopkins? Because the thing came down to who was going to pay for the transportation of the tissue to them. So by the time Danielle got off the phone, it was just taken care of. So they do a lot of work, and I just have to thank you to this day, because I felt like my child did not matter. Thank you.
She matters. And thank you. Okay, so what Vicki was saying is a bit aggressive, even though I thank you for that. The relationship with Hopkins, just like any other institution, is very open. They are a teaching institution, so, there have been changes in their pathology department. So sometimes when that happens, the neuropathologist or the pathologist who typically will perform the procedure for a suspected prion disease case may have left, and there isn't anyone to assume that role, even though we all know here that it is actually possible. But we do still work well with Hopkins. They do contact us in regards to servicing families. They will refer to us, but at this point, they have not recently accepted a procedure for us. So we actually have another provider in Maryland that will perform the procedure for us. But we still receive referrals, we still report results to them. So there's still open communication. We just need someone to fill that role, for them to continue to work on filling the role of someone who will do the procedure.
I was just going to say that I had the opportunity to meet Vicki at this particular conference, and she's a very unusual woman. I spoke with her, and she knew everything about her daughter. I can't believe, and kept every record, and it was just amazing.
You mentioned earlier about social workers and funeral directors and them even knowing that CJD exists and what to do when they have a case. I know the foundation has an educational program for medical professionals and that sort of thing, but how is it pushed out so that a student in a social work curriculum that's going to go the medical route and not social services, or some other type of person, professional that's in training, how is it pushed out to those educational institutions to include this in the curriculum? They're going to deal with cancer cases and heart cases and you name it cases that are very common, but I have a daughter-in-law who's a social worker in the medical world. Without my husband having had CJD, I don't know if she would have, if she had a patient family come in front of her and say, we've got a CJD situation, we're getting discharged, what do? We don't know where to turn next. How do they know about the resources that are available with the foundation, with the Prion Center, the CDC, any of that stuff? So I'm just curious as to what involvement the Prion Center or the foundation has in getting these up-and-coming professionals, whether it's through their not-for-profit associations that work with that particular specialty or whatever, how that's being handled.
You want me to take that?
Yeah, sure.
Okay. So typically, honestly, a lot of the social workers that come across to us, they kind of fall into it, sadly. And again, it's what the diagnosis is. But in regards to, the education portion, like as far as us or the disease being notified through them or through their curriculum, I really don't have an answer for that, to be honest with you. Because most of us here, we just kind of fell into, prion disease. So, and we knew some things as we, in our careers, but a lot of things we learned, coming here to the center. I can only give an example of one of our new coordinators. Through the Mandel School at Case, I initiated a internship because we needed assistance helping with families. And she had no idea what prion disease was. She had never heard of it. They're pretty much taught how to support families through the grief process and things like that. Resources in the neighborhood or nationally, whatever they're able to get their hands onto. So she had no idea what prion disease was until, she came to us through the internship program. So unless it's a part of their curriculum, which more often it's not specifically for prion disease, there's really, no way in knowing. And I will be the first to say I'm not a social worker, so if there's a social worker here who can answer this question better, thank you. I divert.
It's a great question, actually. No, it is not part of the social work curriculum. Maybe it is now, but it wasn't when I was in training. So the way I knew about it as a social worker in a medical setting was having had my brother go through the process. That being said, he passed in 2013, and in the interim years until I retired a year ago, I always took an intern under my wing, because that's just part of our responsibility as social workers. And certainly through my big mouth, they learned about what CJD is. Also, having worked in the setting I did find that we were one of the only facilities in my state that would accept CJD patients, and that was because of my knowledge. And again, my big mouth saying to my boss, we can handle this. This is not something to be afraid of. And then taking it one step further and my training the rest of the medical staff that had to care for our patients, and letting them know that, this is not something they're going to catch. This is a human being that needs care and a family that needs care. So that's the way it's being taught now, and I think it's just what we're doing here today, right? It's just advocacy and making people aware that the disease is out there and a very real disease that needs attention. If that answers the question.
Well, thank you very much for, as you said, your big mouth. We appreciate it, and we encourage further big mouths. So I think we have to move on to the next session, but I definitely wanted to thank all of our staff and faculty members, and especially you all who unfortunately have had to go through this process and made the ultimate donation of your loved one for surveillance and research. We're greatly appreciative. So thank you.